what I'm going to do is I'm going to provide a bit of an overview of home and continuing care in Canada. I think home care is fairly self-evident. I think most of you know what continuing care is, but if you don't, it's a broader system of integrated care delivery that includes home care, residential care, and other aspects. So I'll talk a little bit about home care within the context of continuing care as well. Now, just to start off with, there's been a lot of work that's been done in the past. In about, if I recall correctly, about 1990, Stephen Lewis from Saskatchewan did a paper on home care. And it was the first time that we had outlined the various functions, as far as I know at least. And the way we think about it is that there's three functions of home care: a maintenance and preventive function, which essentially allows people to maintain themselves in their homes and live independently; a long-term care substitution function, where home care actually acts as a substitute for people with higher care needs to residential care services; and an acute care substitution function, either to assist with early discharge so people can get out of the hospital earlier, or to have various programs that keep people from going into the hospital in the first place. Home care, including home support, which is the non-professional supportive services, obviously is a valuable service in its own right and worthy of additional support. However, if you just think about home care and funding goes to home care, it may in fact be a bit of an add-on cost. So in addition to being a standalone service, it can also be a vehicle within this broader integrated system of care to enhance value for money for the whole healthcare system through substitutions of lower cost care for higher cost care with equivalent or better outcomes. So this is a little schematic about how we got to continuing care in the first place. It probably relates a bit more to BC, but I think there were similar patterns across the country. So in the 70s, there was a move to provide a more comprehensive set of services for the elderly. At that time, things were split between ministries of health and ministries of social services, and the decision was made to bring together a focus of services that focus on the needs of the elderly and people with disabilities from both of those types of ministries. So what you had was, in fact, a bringing together of services from hospitals such as geriatric units, day hospitals, chronic care, also from social services. Back in the 70s, a lot of those were long-term care facilities were in social services, group homes. We were just starting to look at adult daycare centers, homemaker services, meals programs. All of those really came from the social services sector. And then finally, from the public health, we had home nursing care and community rehabilitation services. Now, over time, all of these got merged into one area. BC was actually a leader at that time. And in the late 70s through early 80s, we ended up with, in 83, a continuing care division, which was one division within government that was responsible for the care of the elderly and people with disabilities, that integrated all of these services together and coordinated them through what I refer to as system-level case management, where case managers would have all of these services. They would look at the needs of the people, they could match the services to the needs, they would reassess, and so on. But it was a really big change at that point to bring all of this together. So in terms of a short history, home care nursing actually has been available since the establishment of the Victorian Order of Nurses in 1897 in Canada. Continuing care started in the mid-70s in Manitoba, and an integrated system of care, as I mentioned, was developed here in BC into its final form in about 1983. In other parts of Canada, Quebec developed a system of primary care health centers. You may have heard of them, CLSCs, which included home care. Other provinces maintained a separation between home care and residential care. By the early 1990s, about 7 provinces had, at various points in time, one person responsible for the equivalent of a provincial continuing care service delivery system. Now, they didn't necessarily have fully integrated systems, but they had an individual that was identified that had responsibilities for all of those components that I just showed you in the chart before. There was also a federal, provincial, territorial subcommittee on continuing care, which functioned from the mid-1980s to the early 1990s, and I was honored to be one of the inaugural co-chairs of that in 1986. And we had representatives from both home and residential care. Now, from my perspective at least, I think continuing care has been in a bit of a decline since the 1990s or the mid-1990s. The subcommittee on continuing care was disbanded in 92 as part of a broader restructuring of the federal provincial advisory committee structure. And what's happened is that continuing care is not really recognized as a major pillar of the Canadian healthcare system at that time or since about the mid-1990s. The 2004 Health Accord focused on home care, but not on the broader integrated system of continuing care, and the data we collect are only collected and presented on some components, and so there's really no national data on the broader continuing care services and expenditures, and policymakers can't see how big and relevant continuing care is, and I'll explain that in a second. We also had regionalization in the mid-90s, and what happened was things went out to the regions. More recently, Ontario and Quebec have developed integrated health networks. They're called LHINs in Ontario, but essentially they're called networks rather than health authorities, but they do a fairly similar function, not identical, but similar. So in regions, continuing care was, at least here in BC, and I think it happened in other areas, combined with other services or splintered into its component parts. Formal provincial systems of continuing care were disbanded. So before, up to about the early to mid 1990s, continuing care and home care, which was part of continuing care, were part of provincial systems. Then we had regionalizations and things changed a little bit. And what happened was that the systems were disbanded or replaced. There were other services or splintered into component parts. The provincial thing, so rather than having divisions of continuing care, you ended up with a policy and monitoring functions within the provincial government because the services were delivered regionally. And there was a very strong focus on primary care beginning in the mid-1990s, and that took the attention of the policymakers. So up to about the mid-1990s, this is what I call the previous system. You can see, how do we divide up healthcare? We had hospitals for people with acute services, primary care for people who need basic medical care in the population, continuing care including home care for people with ongoing care needs. You had drugs, and you had population and public health, and then other services as well. What's happened since then is we now have hospitals, primary care, drugs, population and public health, and all of the continuing care components are now being relegated to other services. And this is what I was referring to previously. Continuing care was, and it would still be today, if a system existed, the third largest component of public health expenditures after hospitals and primary care, and as such deserves a greater policy focus. So you essentially have people who have a care need. We have experience with a system for those people. That system is actually, in terms of public expenditures, the third biggest system, but right now it's all essentially invisible and non-existent as one system. The other thing that's happened is there's been the focus on long-term home care has been downplayed, and particularly on home support. So I like to make this point. People with ongoing care needs due to functional deficits clearly have health problems or require medically necessary care. However, this care, the services they require to maximize independence and minimize their rate of deterioration are in large part non-professional home support services. This does not seem to be recognized by the current policy discourse. In fact, I've heard commentators and politicians say, well, I'd like to have people come over and clean my house too, But that's not the way that it works. The people who get that kind of service have actually been assessed as being very frail and needing it. So home support is a low-cost alternative to residential care and hospital care. And so this really has to do with that substitution function. And here's a bit of data. I'd be happy if other people did similar studies, but so far this study has held up pretty well. And what it shows is that in the mid-90s in BC, we had a policy where we essentially changed the way we did business and eligibility, and some people were cut from service who were getting essentially housekeeping services, homemaking services, and some were not. So when you look at this, the year prior to the cuts, the costs were fairly similar, a bit of a difference. The third year after the cuts, there was quite a big difference, with the big increase coming into people who had actually been cut from care. And there was a net difference then between those who had been cut and not cut of almost $3,500. What happened was that people couldn't cope on their own. They were more likely to go to a long-term care facility and more likely to be admitted to hospital. So that's the preventive function. Here we have some data on the substitution function. I'm not going to go through all of this. The main point of this is to show that people with similar care needs looked after in the community cost less than people looked after in the facilities. Basically you have this cost differential, and then the question is, well, in the real world, can you do anything about it? And the answer is yes. We showed this, and I'll show you a chart that makes that clear. We think similar opportunities are still possible. We did a study for Veterans Affairs Canada, and certainly this differential in cost that I just showed you was there as well. Thus, home care in an integrated system has the potential to increase the overall value for money of our healthcare system. Now, here's a chart. I don't want to belabor it, but essentially to give you a quick summary, this is a utilization chart, and what it shows is the number of people 65 and over per thousand. In 1985 and 1995, while the component parts are different, the actual total, 163.7, is in fact identical. And what happened here is that we shifted care from money that Treasury Board provided to home care, and we did not increase residential beds very much. So the utilization rate played out this way. And essentially, this differential between 85 and 95, at least on a rough estimate, comes out to about $150 million, which is a fair amount. So if in 95 we had the same utilization as we had in 85, it would have cost us $150 million more. So policy. So there's been a lot of changes, and this is the way that I kind of look at the flow of things. There have been cost pressures. We had big cost pressures in the 90s. They seem to be there all the time. There's also a lack of understanding that continuing care costs almost as much in terms of public expenditures as physician services and more than drugs. So this is the mindset. What's the result of the mindset? The result is we've narrowed the range of benefits to more medical services. We're downplaying supportive services and so on. And we're raising need-based eligibility requirements. I'll talk a bit about that shortly. So what's the consequence? So we've apparently maintained a fragmented system. There's pressure on supportive services for people with ongoing care requirements to be downplayed. There's pressure to redefine home care as a short-term acute care replacement functions as a result of the Romano and Kirby committee reports and the 2004 Health Accord. There's been now a move to move home care into more primary care, chronic care model. That's not bad necessarily, but it's not quite the same as continuing care. There's been a search for new funding options, essentially possibility of long-term care insurance. And really, in my perspective at least, there's been an apparent exclusion of the care needs of people with ongoing care requirements from public policy debate on health services. So you don't know how big the thing is. You don't know how much it costs. It's out of sight, out of mind. You don't really talk about it. And so all the things you hear about is give us more money because the healthcare system is not sustainable, or hospitals or primary care or whatever. And so you're not really involved in the public discourse. Current status of home care. Right now there's two approaches split about evenly across jurisdictions. Some provide assistance with ADLs only. That is, you have to be at a higher level of care need in order to get help. Others still provide assistance with IADLs. So ADLs are things like bathing and so on. They're the functions of daily living. IADLs are the supportive functions like shopping, preparing meals, and so on. Also split about evenly are income tests and user fees for home support. Some provinces have them. BC has always had them. I think Manitoba hasn't. I think they still don't have them. And nursing and community rehab have had no user fees all along. Organization of services are in flux. Many jurisdictions, such as Alberta and Nova Scotia, are now conducting major reviews. Because all of this out of sight, out of mind, the problems are still there. You know, you can see you got a problem. Well, what are we going to do? So then people start seeing, well, what can we do? I'm not going to spend time on this, but in talking to people across the country, the most common services at the present time for home care are case management, information and referral. You're familiar with these things. Home nursing, community rehab, daycare, community respite, palliative care, technical aids, self-managed attendance services. So there are other services, but they're not quite as common across the country. These are the most common ones. So if you're looking for a core set of services, this is not a bad list. Then for home support services, which are a bit near and dear to my heart because I think they really, it's that conundrum that I talked about. You have a medical requirement, but in order to assist you with your functioning and your medical condition, you need supportive services. So here's a list, basically bathing, dressing, grooming, various safety, cleanup, laundry, and so on. So in conclusion, what are the key policy challenges and choices going forward? And I've put these kind of as questions, and it'll be up to various people to address them, politicians, the public, and whatever. But to me, these are things that if you're going to move forward constructively, that you probably need to pay some attention to. Who should be eligible for home care in terms of level of need? The full range of people or only intermediate to high care needs clients. So this is the distinction between where you're only providing care for ADLs and where you're providing care for the larger population. The danger I see when you're only providing it for higher care needs people is as money gets tighter, you ratchet up the eligibility requirements because you're already on that track, and you end up with a very, very high care needs group, and everybody else is not eligible. Who should pay for what in terms of user fees? What's an appropriate integrated system of which home care and home support should be a part? Continuing care, or this new chronic care, primary care model, or some other hybrid. Frankly, my own view is that we should have a continuing care system for a broad range of services, and it would actually be a help and a support to have the chronic care model and primary care as a component of that system for the really high care needs people. What kind of case management should we have? Typically, case management, you've looked after people in the community. When they go into a facility, the case management gets transferred over. In BC and in one or two other provinces, at least for some periods of time, we've had what I refer to as system-level case management, where the case manager stays with the client no matter where they go, because there are going to be transitions, home to residential care, to hospital, back to residential care, to supportive housing. There are all these transitions, and each one of those requires a little bit of extra help. And so I think we should be having system-level case management. And then what constitutes sustainable funding? A lot of the things we hear about now are, oh, well, there's not enough money. Well, that's why some people just provide care for the higher care needs people. Or you say, well, really, we're not providing enough care. People have these needs, but we don't have enough money to provide them the care that they need. So what is sustainable funding? So that's my presentation. Thank you very much.